Thank you. Well, good afternoon. Thanks very much for sparing the time to come here. It's a double act from myself and Junaid. So what I'm going to be talking about is really some of the international best practice, and in particular associated with a report I published that was published by 2020 Health a couple of months ago called Making Connections. Just a little bit more about who I am and who 2020 Health are. 2020 Health is an independent healthcare think tank with a particular interest in technology. I've written a whole series of reports around the National IT Programme, personal health records, telehealth, and a variety of other things. And I'm also, with another hat on, an advisor to MSD. So what I'd like to talk about is something you may or may not be aware of, but there is an NHS leadership exchange programme underway between the NHS and the US Veteran Affairs. The VA, as they're colloquially called, is a global leader in the exploitation of digital health. And the NHS, and this is the programme has been funded through the 3 Million Lives initiative, has really created the Leadership Exchange Programme as a way of gaining greater clinical engagement and business leadership around the adoption of telehealth. The trip, I was facilitating the last trip to Minneapolis in May. Colleagues of mine from 2020 Health will be going out over the next 2 or 3 months on further trips. And what's important about these trips is that they're not just clinical and CCG leaders, but they're also leaders from NHS England. So I think in time we'll start to see a real sea change in terms of national policy and also local initiatives around the use of digital health. Why the VA? Well, the VA, I'll say a bit more about them shortly, but 20 years ago they were essentially in the recovery suite. Over the course of 20 years, they've transformed themselves to be one of the high-performing systems anywhere in the world. And their model configuration in terms of integrated health and social care has many similarities to the NHS. And in particular, they make extensive use of digital technologies. And you can see in the bottom left-hand corner, over the course of, 20 years, the reduction in hospital beds that have been accomplished. So they've moved from very much a hospital-centric, organizational-centric organization to a patient-centric one. So on this slide, just want to share something about their mission statement. Now, I don't know about you, but sometimes mission statements are a bit boring and motherhood and apple pie. But when we saw this mission statement and had the opportunity to actually hear and speak to carers, patients and clinicians in the VA, we actually felt that mission statement is being lived out. And this first 3 words of honouring the vets was very profound, a real sense of pride on both sides, both the patients and the clinicians, that they're able to serve these patients. So they're delivering what we saw was real patient-centred care. And you can see it at the bottom of the slide, a couple of quotes. These are from the NHS leaders on my trip and the way in which they responded to what was being said. So what they're trying to do is build a system around patient needs, and I'd really say that's a whole person needs, including patient convenience and the role of carers, not just clinical needs. And it's also aiming for just-in-time care, eliminating unnecessary, unplanned care, and much more of an anticipatory type model. So if we compare the two systems, well, what is the VA? The VA essentially provides healthcare largely free at the point of care to those who've served in the armed forces in the US. Not all of those who served in the forces are eligible to join the VA. There is a criteria to follow, but nonetheless, it's a nationwide system corporately funded through Congress, and many similarities to the NHS, primary care driven, lots of similar issues around treatment of long-term conditions. Perhaps some of the dissimilarities are typically their patients are older and sicker. They do have women patients, about 10% of the population is women, but no kids or anything like that. They also have a higher, a higher propensity for mental health, and homelessness is a major factor. You can see from the table the disease prevalence, so substantially greater in general terms with VA patients. And I've heard it said here on this side of the pond, you can't compare the two. The VA is a much more rurally based system. Yes, that's true, but actually over 50% of their patients are based in urban configurations, and the application of digital health has been as significant with those populations in terms of convenience, workload distribution for the system, and so forth. So it's equally valid. And again, you get a sense of what the NHS people were saying. The VA is still very much on a transformation journey, and it was very interesting with GPs and CCG leaders amongst us to see the type of primary care transformation they were going through towards much more of a team care type of approach, and increasingly using more and more data, not just in the planning of care, but in patient consultations. And we saw that in terms of some of the patient consultations we were able to sit and watch. In terms of digital health, which I'll go on to explain by what they mean, roughly 18% of patients in the VA are now getting their care virtually. They're aiming for 50% by 2015, and without telehealth, which I'll come on to shortly, 42,000 would have to leave home and move into care homes or nursing homes. They have a common set of platforms on which to build, which gives them a great place to build on, both from an electronic health record and technology process. Their modalities include both telehealth and telemedicine, personal health record access from the VA, and secure messaging to clinical teams. Apologies for sort of scooting through these slides. I'm anxious to give good time. And in terms of telehealth, etc., they're actually providing telehealth up and down the triangle, and increasingly we'll see something like 2/3 of the patients in the VA on some form of home telehealth, particularly in the mobile world. The patients love it. Here are some quotes that you might see in terms of their side of the bargain, and quotes of patients we watched during patient consultations and their kind of feedback. Big promotion of self-care, which we know is undergoing here, but they actually provide a series of tools and coaching around it. And I'll skip the evidence slide, you may be aware of it. I'd just like to come on to the final point, which is, so what can we learn from it and what's going to happen as a result of this? It comes down to, it's about change, it's about leadership, it's about coherent structures, it's about taking risks. The chief exec of the VA, who we spent a couple of hours with, emphasized the fact that there was freedom to fail in the system. They have the ability to bring new services, new digital health services on stream in about 3 months. A series of simple metrics that they drive and incentivize performance around, substantial investment in training and workforce development, and also it's kind of embedded in their culture. So I think the challenge for us all, and the people who were on my trip particularly, came back thinking the NHS is full of pockets of excellence. How do we really scale this up and make the level of impact and outcome that the VA have achieved through the redesign of care to take advantage of digital health? How do we make that integral to the NHS? Thank you very much. Look forward to some questions, or I'm available afterwards at the MSD stand if you'd like to ask more questions around the VA. So over to Junaid, and you can download this report from the 2020 Health website. Please do take a look at it. It's got some interesting lessons to learn.
Thank you very much, John. Junaid, as well as being part of MSD, Junaid, you really are a practicing practitioner in Greenwich, so part of Southeast London, and part of the London dimension, where we are trying to do something specific with veterans. So again, there is some consistency in this message. Over to you.
Thank you. So good afternoon, everybody. My name is Junaid Bajwa. I'm a GP in Southeast London. I work in Plumstead at a not so great practice, or it used to be not so great, and now we've tried our best to transform it. We've used technology as best we can to both optimize some of our patient care, and I'm a strong believer in both system change and how technology can enable that to happen. When I started working at this practice, so just to give you a bit of background, it lives between two gurdwaras, two temples, an African church. It has lots of disease around this, so lots of cardiovascular disease and lots of diabetes. I didn't really know where to start. And through making some small changes, I've been very, very fortunate to been offered lots of different roles in my short career so far. But what I still do is learn from these opportunities and try and impact that patient experience that I have in that consultation room. So I'm here with my hat in terms of the MSD's medical advice, and I think what we need to think about is the system is telling us about telehealth. However, I think what we need to do is take a step back and think about how do we enable our patients to look after themselves, and how do we enable self-care. Once we've decided that actually we want to address self-care, what are the tools that we need to employ in order to deliver self-care? And telehealth is amongst them. So just in terms of definitions, what telehealth is, it is about the physiological measurements that you can remotely monitor on an individual in the background. It's not specifically around Skype video consultations. It's not specifically about having that video consult with a patient, but it is about monitoring somebody in the background. As those of you with an interest in this space may be aware, there was a huge study done back in 2007 called the Whole System Demonstrator by Department of Health. Results for that are still being published now, so we're still 6 years post and we're still learning about it. It was a randomized control trial. It has lots of critique against it, but there are some key lessons that have been learned as a consequence. Amongst those lessons learned were about the leadership that was present in the areas that they tried to demonstrate telehealth in. How did they go about identifying the right patients? What engagement did they have with those patients? And what was the service redesign around it? And what was the integration? So John Oldham says that if telehealth is to work, you need to change the system and install the kit second. I'd have a slight flex on that, and I'd say actually the system is there. We need to just enable the system to do more at the moment rather than change it and reinvent the wheel with it. And it's not necessarily about the kit, but what is wrapped around the kit. If I just take you through a journey of an individual that would have a long-term condition. So I was thinking, if I was a person and I had diabetes, or if I had COPD, what would happen to me? Apologies that this is a really busy slide, but hopefully it'll give you the message that I'm trying to convey. I could be at home, I could have COPD, or I could have heart failure. If I feel unwell, I could call 111, I could call my GP, I could go to a pharmacist. If I'm known to my community matrons, I could go to them. The system doesn't share information in any way, shape or form. I'd be anxious. If I am very unwell, I might get admitted into hospital. If I'm admitted into hospital, I may end up on a specialty ward, or I may end up on a general medical ward. When I'm discharged, it could be on a Friday night. I've had patients that have been discharged straight from ITU home because there was a bed capacity at the hospital with no involvement, with a letter to say GP to follow up within a week. But it's a straight handover. This is slightly an unsafe and slightly chaotic system. But what we do in hospital is that we monitor those patients. And we're doing regular monitoring for both our reassurance and for the patient's reassurance so that we know that they're safe to be discharged home. What we're doing in the community is monitoring them. And what we're doing with our community teams, who I think are actually the integration catalysts, is monitoring them. Where I believe telehealth fits in our current space and with our current environment is probably both within at that point of discharge in the left-hand box, and how can we enable our community team colleagues to try and do better and do more of what they do really, really well, which is engage the patients and trying to enable them to self-care. The MSD model has 4 distinct components. One is around professional engagement. The other is key, which is around patient engagement and patient identification. One is around remote monitoring, and the fourth and final piece is around care integration. For the remainder of this talk, I'm going to focus on what I perceive to be one of the most important key components to this, which is around patient engagement and patient identification. Professional engagement needs to happen in the background. You need to have professionals engaged to understand what is telehealth, what role do they play, make sure that GPs don't perceive it to be a data trawl which they're going to have to go through on a day-to-day basis on top of what they're managing, but for them to be engaged and understand actually if a patient comes in and they're on telehealth, what message is that healthcare professional giving? Be that in secondary care, primary care and community care. There's a lot of noise in the system about risk stratification. And I think what we have to do, again, is take a step back and think about who are we risk stratifying for and for what purpose. CCGs will have a different intention and different lens they need to apply. Secondary care providers should also be involved in risk stratification and will have a different lens. Primary care will have a different lens, and community care will have a different lens. If we could, we would try and put down a model where you would be able to share community care data, mental health data, social care data. Our hands are tied at the moment following Caldecott 2, but we have to think about what are the needs for the different specialities and different parts of the system when they're thinking about risk stratification and risk optimization. In primary care, is it really about what I do with my data set to try and identify people at a lower tier of the health pyramid to prevent them becoming slightly higher up in that pyramid? In secondary care, is it about knowing that someone's at high risk of readmission and then doing something at that point of discharge to prevent them becoming that high risk and preventing them from becoming readmitted? And how does community care support that? MSD has a legacy in IT, so one of the tools I'll just very briefly show you is a tool that we've developed just for primary care, which is the long-term conditions tool. If I was to interrogate my data set at my practice, I have 5,000 patients. I wouldn't be able to, hand on heart, be able to tell you how many patients live on different long-term condition registers. The tool allows me to see in the background how many people live on different long-term condition registers. So here I know that one person lives on 7, and RAG rate them depending per NICE how they're optimized in terms of their individual metrics. I could see that although this person lives on 7 registers, including dementia, heart failure, prostate cancer, arguably he's okay. He's relatively well managed. Yet I have some people who live on just a single disease register, and 25 of them are poorly managed. Are they my vulnerable patients? Are they my mental health patients? What can I do as a virtual review in the background to proactively manage them? Indeed, how many times are they having an interaction just within primary care? The average number of times, and any of us in the room should be going to our GP per year, is 5.5 times per year. That's what the tariff suggests. Yet I have people coming 45 or more times into the practice per year. And I'm also then challenged by access. I'm challenged by how I can support these other patients who aren't actually being optimally managed. And could I therefore develop a long-term conditions clinic for these patients? And could I enable this cohort of population to self-care in a different way? Can I drill down, and this is anonymized data, I could drill down and find out actually what makes them red and target my consultation around that. So when they come in for that consultation, I'm focusing on their needs around their health, but for the rest of the time they want to come into the surgery, I can focus on their fungal nail infection or that other concern that they had that QOF doesn't recognize, and trying to improve their experience. Applying a similar model, I think we could do something very clever in secondary care that doesn't take much time at all. Using tools that exist currently, so either PAR30 or a LACE algorithm, could I try and encourage my providers to better discharge plan? Could I ask them to think about what is the risk of that person at the point of discharge? Not just send a discharge list of medication and what investigations have happened, but to say, for them to have a conversation with the patient and say, did you know that you are at a slightly higher risk of coming back into hospital within the next month? And as a consequence of that, this is what we should be educating you to do in a different way. Discharge Plus is another tool that we've developed for secondary care. It looks at length of stay, acute admission stay, comorbidity using a LACE algorithm. It then suggests whether an individual may be suitable for something such as telehealth. You can drill down and identify what is the rationale. So if you have a junior sister or a junior doctor trying to do the discharge, they can be educated around telehealth, so we're conveying the same message across the system. You then go through a discharge checklist. Arguably this should be happening, and many non-clinicians would be surprised to know that actually this doesn't tend to happen. You don't tend to have a conversation with the senior nurse or the consultant at the point of discharge advising you on what medications have changed, what is your actual condition that you were admitted into hospital for, what can you do when you go home, so when do you contact out of hours, why do you need to go and see your GP within a week, as opposed to make sure you see your GP in a week and there's no information in the system. You could then see if someone is suitable for telehealth, consider the exclusion criteria, perhaps based on the WSD findings, which are on the left-hand side, but also consider what should be the inclusion criteria for something like telehealth, such as the ability of an individual to see, the ability of an individual to hear, the ability of individuals to engage with technology. It may not be for everybody, but at least we're trying, and at least we're trying to impart some element of self-care back into the patient. When it's finished, you'd get an overall score. This score can be coded in EMIS systems, System 1 systems, and Vision systems, and a letter can be generated to be sent to the GP to let them know that, for example, secondary care are advising that this patient may be suitable for telehealth, and secondary care, if they're offering telehealth, may be providing that on behalf of that patient's discharge plan. Patients may then be able to have a reduced length of stay in hospital, and hopefully we're going some way to reduce their readmission rate as well. I think the remote monitoring piece is interesting, and MSD have, since I've been with them over the last year trying to look at this, have done a whole tranche on this. We will inevitably in the future have step-up and step-down telehealth solutions, text-based solutions and more solutions based on the medical hub. The smartphone area is very interesting. It could be Android-based, you could have iPhone apps, it can be remotely managed. There are pros and cons to each one, and MSD has a pipeline in terms of thinking about different stages of the pathway, depending on what the patient's individual need is. You can't do all of this without some element of service redesign and that engagement piece again. So it is about engaging with the IT people within the locality, it is about engaging with the CSIROs and the Caldecott Guardians, and that is all part of a service package that comes with the telehealth offering. But the core to this is really about the patient and what the patient's individual needs are, and what can we do as a health system and a health service, similar to what they've done with the VA, in trying to encourage patients to take a little bit more ownership about their condition, so that when they come in, they shouldn't feel guilty that they haven't done their diabetes check because they perceive I'm going to have a go at them. They should feel that perhaps they should have done that diabetes check because it has an impact on their own outcomes overall. And we need to be better at having those conversations. So hopefully within that short space of time, and I'm sorry it's a bit rushed, I've taken you through perhaps an option where self-care fits into your localities, or where self-care is the place where we want to be, and one of the tools that may make it happen. Thank you very much for your time.
Thank you. And it would be helpful actually if you both went back up on the stage, because I think we have a few minutes for questions. And if there are any questions, please could somebody raise their hands, and I'll try to find out where they are and who they are. Till you find out whether you start to formulate the questions, let me kick off with some questions for myself. I think the stuff which they're doing in the United States is particularly interesting, because the merging of records is something which really can make a difference to somebody's life. There's some other work which the VAs have done, which I think is part of the same sort of way of thinking, and that's around the wounded warrior, which is the management of people who come back from Afghanistan and the Middle East, often in a pretty difficult and traumatic mental state. And all it consisted of is an electronic hug every day with these individuals over their mobile phones to check whether they were all right. And literally all it was is asking people whether they feel okay, with the potential for these people to be able to say they don't, and then of course to mobilize somebody to go back and see them. That had a really quite transformational effect upon the number of suicides over a remarkably short period of time. And I think it just goes to show how much we can do if we start to really take on board what was described here and start to apply it to the systems that we have in place. And the potential is enormous, and we haven't really done this. We have retained control as clinicians rather than ceded that control to populations. So have you seen any of the mental health work they have done in the US in terms of veterans? And
yeah, in fact, I should have said the VA looked after us splendidly, and in particular we had 3 members of the local telehealth team to work with us, including a psychiatrist. So he spoke to me about some of the joint initiatives they were doing with the Department of Defense around current military campaigns, and the way in which they then plan for what kind of need would this put onto the VA end of things. So yes, we saw that. We also heard very much how popular video conferencing telemedicine was for patients with mental health conditions. In many cases that was their preferred channel of receiving care, to be able to do it virtually from the home over their laptop or tablet, dialing into a specialist at a VA medical centre.
Thank you. We have time for a question. Lady in the front, please. Get the microphone. Thank you. Just over there. Could you say who you are, please?
Ramila Mistry. Thank you very much for both your presentations, very enlightening. Junaid, you took us through the kind of processes to identifications of patients. Just wanted to know in terms of the implementation too, then I don't know whether you actually, how far you've got in the implementation as to implementing the telehealth within it and linking it through secondary care and any other community care services, and possibly what was the outcome of those areas?
So I probably should have said, so this service launches pretty much this week, and MSD is in the process of, it's actually engaged with 2 demonstrator sites where a lot of this background piece is functioning. I think it's very early stages with outcomes, and what we're doing is engaging with an academic partner to really tease through what the academic evaluation to this will be. And we're working with similar academic organizations who have done the whole system demonstrator trial as well, so they have some experience in this space. But I think part of it is it's kind of hearts and minds first, and most people believe that there's an element of this that will work. So Charles is an advocate of it, clearly. John is an advocate of it. I've had a chance to see where processes don't work in primary care, where processes don't work in secondary care, and I've been on the receiving end when patients come back slightly distraught saying, I've been discharged and I've been told to come and see you, but I don't really know why. And all you've done is a blood pressure check for me. I've just done that myself at home. And there's elements of this. And from those frustrations, I think what we just need to do is take a step back and reflect on the system about how we can improve it. And if we just put the patient at the center of what we do, our collective challenge, be you a commissioner, provider, whoever you might be in the system, is to try and improve patient outcomes. And the collective challenge therein lies, what outcome do you wish to improve, and how do we, as an NHS, enable some patients to take ownership over their condition? So we're doing that, I think, in primary care little by little, but we have to be a bit braver in terms of taking that next step. And I think that secondary care discharge piece is a big piece for me. And if I could build that into a sequence locally to say, actually encourage every single person at the point of discharge, I want a conversation post, and put Francis in light with it as well. So post Francis, encourage you to have a conversation. I think that would be a step in the right direction. And even that conversation will improve outcomes. I truly believe that.
Thank you. Could we say thank you in the traditional way for your presentation? Thank you very much.